Good morning and welcome back. I hope that everybody is doing well. First, before we jump into the video today, I wanted to do another quick introduction for anyone that doesn't know me or what it is that I do. So my name is Brittany Holzbeck. I am a family nurse practitioner. I've had a few people asking me what my specialty is, and I did get my master's degree in family practice. So I am trained to treat all ages, both pediatric and adult. Currently, I work at an urgent care, which has been a really nice transition from my nursing experience, which was emergency medicine and then acute care as well. So the transition has been, I think, really smooth. I have a great passion for trying to take the best care possible of my patients, and so this definitely means staying up to date on science-based medicine. Another passion of mine is teaching and sharing information that I learn along the way, both in my studies and in my practice. So you'll see that's predominantly what I do here on this YouTube channel is I share educational stuff, and it's really related to nursing or, advanced nursing. So for today's video, I'm going to discuss what it is that you can expect working at an urgent care as a nurse practitioner. I've just got a lot of questions recently regarding the topic, and so I thought I would devote an entire video to discussing the subject. Alright, so I have some notes here in case, just so I don't forget anything that I think is important to discuss with you guys. Things that I think will really help you if you are going to work at an urgent care, or if you're just curious, if you would be interested in the future. I think this video will be helpful for you. For starters, urgent cares are open a lot of hours. For example, my urgent care is Monday through Friday until 10 p.m. and then on the weekends until 6 p.m., including holidays. So not quite the 24/7 that the hospital offers, but more than the typical 9 to 5 Monday through office offers. So there are lots of hours available. Some people see this as a con because they don't want to work afternoon shifts or weekend shifts. For me, this is a benefit because I have small children, and so it's easier for me to coordinate, my scheduling. So our shifts are a variety of lengths. 5, 9, and 12-hour shifts are the typical shifts at my urgent care. I often like to do the 9-hour shift, not quite the 12 hours that I used to do in the hospital, but it still makes me feel like it's worth my time. And I'm actually part-time. I'm not a full-time employee, and I don't want to be a full-time employee until both of my kids are in school full-time. However, I do think that where I'm at now, I will stay, and hopefully in the future, I will work there full-time. Another point is working at urgent care, you may oftentimes be the only provider on staff. At least this is absolutely the case where I work. Oftentimes, I am the only provider on staff. So I think my best advice in these situations is to just have resources at your disposal at all times. Textile resources, of course, like maybe your EMRA antibiotic study guide, which I know I've told you guys I use all the time, or Up to Date, which I obviously love. But also having human resources, so people that you can call and contact and discuss with. It's really helpful to have those resources available to you if and when comes a time, and I say when because it will happen, it happens to everybody, when you don't know exactly what you want to do with the patient. So working at urgent care, you have to be comfortable treating sick patients. Again, I can't speak on every urgent care. Not every urgent care is going to be exactly the same, but I think the general theme of an urgent care is you're treating acutely sick people, and so you really have to be comfortable with being around symptomatic patients. I know, and I'm not going to get off on a tangent on this, but I don't also necessarily agree, but there's so many primary care offices that still aren't seeing, sick symptomatic patients, and so they are funneled to the urgent cares. And in this situation, you really have to gain a familiarity and a level of comfort in working with sick patients. And, taking necessary precautions is going to be a big part of your practice because you are working with sick patients. Working in that type of setting, you just don't have the luxury of saying, oh no, we don't treat symptomatic patients, or we're not seeing symptomatic patients. So my next point is you will get to use lots of hands-on skills. And for me, this is a huge perk. This is what I love. This is what I loved in my nursing career. And this is still what I love in my career as a nurse practitioner. Actually, when I was a nurse, I really thought maybe I wanted to join the IV team. I just love hands-on skills. So working in the urgent care setting has been such a great opportunity for me to still use, all these skills quite frequently. So of course, suture repairs or laceration repairs, those come in all the time. And then also incision and drainages, or INDs, those come in a ton. Just recently I've seen patients coming in to have a fish hook removed from their finger. I even still find myself doing IVs and lab draws because I like to keep those skills alive. There are other examples too of just hands-on skills. For example, like assisting with splinting or treatment of epistaxis. I mean, there are just lots of opportunities to use your hands in practice. That's your type of thing too. So this point here I think is really important, and it's that understanding working in the urgent care, there's very limited, obviously, continuity of care. And so you have to gain, a level of comfort with that, but you also have to be comfortable in educating your patients on this, that some things are not properly managed in an urgent care setting, and they have to be referred back to, either their primary care or hospital or whatever it is. All right, so I wrote down some examples of this so I could really try to clarify what it is I'm trying to say. So complaints of chronic diseases, for example, like depression or ongoing poorly managed hypertension or heart failure, diabetes, dementia, worsening dementia, all of these things really need to be managed by a primary care. If you're starting them on a medication like an SSRI, that requires follow-up. If you're starting them on antihypertensives, lab work is indicated. There's a lot that requires follow-up and continuity of care, and that's really not what the urgent care is about. And so sometimes that's just a lack of education. That's one example, the chronic illnesses component. Obviously, primary care is best, but also things where it's going to require an immediate follow-up. For example, I had a patient who was short of breath and had a warm, tender calf and was post-COVID 14 days ago. And I was deeply concerned about a pulmonary embolism. And he was asking me if I could write a script for outpatient CT. And if it was a pulmonary embolism, then he'd go to the hospital. And this is a great example of something that that patient needs to go to the hospital, because if they do determine that he has a PE, that requires immediate action. You don't want to have that liability on you. My point is, working in the urgent care setting, you really have to be comfortable with the decisions that you're making, because you don't have continuity of care with those patients, generally speaking. So whether it be that they're safe to go home or they have to go to the hospital or follow up with their primary care, whatever, you are just a step in the process. Hopefully that all makes sense. I've tried to portray that in a way that was easy to follow. I don't know if I did, but I hope that makes sense. If it didn't, then let me know and I'll try to clarify that again. To end the video, I thought I would give you a quick rundown of the typical patient load in one of my urgent care shifts. So I pulled up my chart from the last shift that I worked, and it was Sunday. I worked from 11 to 6, so 7 hours. For 5 of those hours, I did have a partner, another provider that was working with me, so that was really nice. It was really great to divide up those patients. Otherwise, it would have been a super busy day. Our weekends are very busy, though. So in my 7-hour shift, I did see 25 patients. So roughly 3.5 or so patients an hour, which is honestly, that's pretty good, because there are many shifts where I will be working, I see 5, even 6 patients an hour. So that is a very comfortable pace, I feel like, when I'm seeing about that approximate number of patients. I wrote down a list here. So the most often complaints that I see, those include upper respiratory symptoms, of course, like sore throat, stuffy nose, fever, cough. Orthopedic injuries, again, is another huge component of the urgent care setting. And I actually made a video previously about when to x-ray your patient. It's super useful if you're going to work in the urgent care. I recommend that you watch it, because a lot of orthopedic injuries do come in. UTIs, that's a huge complaint that I see a lot. Wound repair, obviously, like I said. Eye injuries, I see a lot of eye injuries. I never realized how frequently people get corneal abrasions. I mean, why would I? But it does. It seems like it happens very frequently. And in those patients, you have to be able to do the tetracaine and fluorescein dye to check for the corneal abrasion. You're always checking for any debris or foreign body in the eye, as that's an immediate referral to an ophthalmologist. If they wear contact lenses, it's really important that you cover for Pseudomonas. So all of these different things. And the EMRA antibiotic guide goes over that really well for you when managing a corneal abrasion. You can look at that, obviously up to date too. But I see a lot of those in the urgent care setting. Headaches, I see a lot of headaches, and then also allergic reactions. That seems to be something I commonly see as well. I also do sometimes see things like nausea, vomiting, abdominal pain, chest pain, dizziness, and complaints like those are obviously the ones that take up more of my time. A lot of the other ones, are generally pretty simple and repetitive, but complaints like abdominal pain or dizziness, chest pain, all of those obviously tend to require a further evaluation and a bigger workup. Depending on the complaint, there's usually questions that I ask every patient with these more like trickier chief complaints. So for example, if the patient is coming into the urgent care for chest pain, is it reproducible? If it's reproducible chest pain, meaning that if I sit there and push on their chest, it hurts them, that's extremely comforting to me. That's generally musculoskeletal in nature, like costochondritis. I feel much better if that chest pain is reproducible. If it's vomiting and I am concerned for hydration status, you can always check the urine for ketones or proteinuria, and those are really big indicators for hydration status. And you can always PO challenge them, meaning you give them Zofran, see if they can tolerate keeping fluids down, and if so, then they generally can be sent home. If you have the means to do IV fluids in your setting, like we actually do, of course you can give fluids. Then you have to factor in other things, like are they a heart failure patient or whatever. Obviously I'm not saying to throw a liter bag at everyone vomiting and send them home with some Zofran on their way. So abdominal pain, that's tricky. That's my least favorite. I've said this before and I stand by it. It's very tricky because a ton of stuff is in your abdomen. Like there's a lot that's in there and a lot that can go wrong. There's some things that I ask though with every patient that's having abdominal pain. Are their vital signs stable? Right off the bat. And that's with every patient obviously, but are their vital signs stable? Have they experienced this pain before? Do they have rebound, tenderness, or guarding rigidity of the abdomen? Because that oftentimes indicates some sort of inflammation. And that, based on research, is definitely more concerning for an acute abdomen. If they are of childbearing age, you should get a pregnancy test, make sure that they are not pregnant. There's no concern for ectopic pregnancy. If you have any concern, obviously, for cardiac involvement, then an ECG should definitely be done. Elderly patients with abdominal pain, that's really the tricky one, and that's because older patients, that means 65 and older, they are 6 to 8 times more likely to experience mortality due to abdominal pain than younger adults. This is from UpToDate. So really, with elderly patients and having, abdominal pain, these patients, we have a higher level of concern for an acute abdomen. And my threshold for referring them to the hospital is like way lower. If your patient is having dizziness, check for neurological deficit. So a head-to-toe neuro exam, reflexes, checking their pupils, checking their grip strength, making sure that they don't have any deficits there. Obviously, if they do, then they should go to the hospital. And then again, too, dizziness, are you concerned for cardiac involvement? You have to do some critical thinking and reasoning with each patient that, complains of dizziness. Or are you considering something more like BPV or a benign paroxysmal vertigo? Hopefully I said that all correctly. And in these circumstances where I have a patient that's complaining of dizziness and I'm concerned whether or not, outpatient is appropriate or if they should go to the hospital, there are certain questions that I always ask. Again, are their vital signs stable? How's their blood pressure? What about their blood sugar? Am I concerned for hypoglycemia? Do they have a history of vertigo? Because that is very reassuring if they have a history of vertigo and this feels like their vertigo. And then I always ask, does your dizziness feel like the room is spinning, or does it feel like you're going to lose consciousness or pass out? If they tell me that it feels like this room is just spinning, the patient might find it very alarming, but when I hear that the room feels like it's spinning, that's more comforting to me. That's more in line with vertigo. Whereas if they tell me that they feel like they're going to lose consciousness or pass out, there's like a list of things, now that I'm concerned about. And if you're really leaning towards vertigo, then try a dose of meclizine or Antivert. You can even try the Epley maneuver, if you're familiar and know how to do that, and see if their symptoms begin to resolve. And if they do, that should be very reassuring to you. Finally, for pediatric patients, I see so many people in practice that are actually really nervous when they are about to treat a pediatric patient. There's a lot of anxiety around treating pediatric patients. With pediatric patients, I go in asking these questions every time. Again, are their vital signs stable? And then, of course, appropriate for their age. If they have stable, normal vital signs, that already right there is very comforting. And then how are they responding to their environment? If I ask the parents or the caregiver, do they seem to be behaving normally to you? Those are really reassuring signs. Are they eating and drinking? And really, we're even more so concerned with drinking, because if they're not feeling well, it's very common to have a decrease in appetite. But really, our concern with children is if they're able to maintain their hydration status, that they're not becoming dehydrated. And again, of course, if we're concerned for that, we can look at things like a urine sample or their vitals and make sure that we're not concerned, for dehydration. Also, are they peeing and pooping okay? If they're having normal output, then that's reassuring that they are maintaining adequate hydration. If I can answer yes to all those questions, yes, their vitals are stable, yes, they're behaving normally, yes, they're able to stay hydrated, yes, they're peeing, they're pooping, all of these things, then I'm pretty comfortable. All right, well, I maxed out my memory card on my phone, but what I was saying was if I can answer yes to all of these questions, then I'm pretty comfortable sending them home safely with their caregiver or their parent and just having them follow up with their pediatrician. Well, I think that's going to be it for today's video. As always, this discussion is not all-encompassing, and I always encourage you to do your own research and studies when prescribing medicine or practicing medicine. Hopefully, you found it informative and helpful. Don't forget to like the video, subscribe to the channel. I appreciate the support, and it helps me to continue making content just like this one. And as always, go out and learn something new every day. And until next time, wish you guys the best.